Good afternoon, everyone. My name is Johnette Payton. I am the Health Promotion Project Manager here at North American Management, and I'd like to thank you for taking the time to attend our webinar today. The topic of today's webinar is Emergency Preparedness for Community Health Centers. The learning objectives for today's webinar are, 1, to understand the National Incident Management System requirements for healthcare agencies as of July 1st, 2012, understand the basic of incident command systems and the development of a health center incident command system chart, discuss an emergency operations plan template for health centers, understand the resources required for health centers to carry out basic patient decontamination and the personal protective equipment that is needed, discuss causes of patient surge and the health center role in an event, and understand the resources in place in Alabama, particularly at the University of South Alabama, and the availability to others. Today's presenter is David Wallace. He is the Director at the National Center for Disaster Medical Response. Mr. Wallace has 25 years of experience in public health, emergency preparedness, and disaster response. Trained as a veterinarian, Dr. Wallace joined the United States Air Force in 1987 as a public health, readiness, and mobility officer. After 5 years of active duty, he moved to the Mobile County Health Department in 1992 and served as the Emergency Preparedness Coordinator. In 2003, Dr. Wallace became the Director of Preparedness Training, Center for Strategic Health Innovation at the University of South Alabama. The Advanced Regional Response Training System has been extremely successful, training over 10,000 healthcare professionals in the state of Alabama, offering basic roadshow, simulation, and certification program courses. The department's programs have received state, regional, national, and international recognition and have been renamed the National Center for Disaster Medical Response. Next, I just briefly wanted to provide a few facts for everyone, just to kind of tie into the purpose of this webinar. Many low-income families live in areas that are prone to natural disasters. In a survey of websites that provide information on emergency preparedness, 49.5% make no mention of racial ethnic minorities, 37.9% acknowledge the importance of preparedness as it concerns these populations, and 12.6% provide information, materials, or publications that focus wholly or largely on preparing diverse communities. Just as a reminder, copies of these slides will be made available to all attendees. They will be mailed to your email address. And if you have a question, you can type your question into the questions box on your control panel. If you are dialed in through your telephone and would like to verbally ask the presenter a question, use the raise hand icon on your control panel and your line will be unmuted. And we will respond to all questions at the end of the webinar. Now I would like to turn the webinar over to Mr. Wallace.
Good morning. My name is David Wallace, and just want to make sure that everyone can see the screen. First, to start, I'd like to give you a little history of our program here. In 2003, the Alabama Department of Public Health funded our center, and it started out as a emergency management program for healthcare facilities in Alabama, primarily hospitals. And over the years, we have grown this to include all healthcare facility types, including community health centers and nursing homes, emergency medical services. So we reach out to all healthcare facilities in the state. There's probably 400 to 500 that we have access to, so they're all eligible to come to our classes, and they can come to those in Mobile, or we can do those as an on-site program at a facility, and we'll touch on all of that in just a little bit. But first off, I'd just kind of like to start and talk about what we provide for community health centers in Alabama, and if there's any way we could help any of you, we're available for that. Today, just to go over the topics, same list that was just mentioned a minute ago, but we want to talk about NIMS and the requirements for community health centers, how Incident Command fits into that system, what we've done for community health centers in Alabama and what would be available. We've also put together a planning guide. It's a disaster plan template for community health centers. We took some of best practices from a lot of other locations, and over the years we've put together what we think is a comprehensive plan that's a good document for community health centers. Talk a little bit about chemical hazards and decontamination. In Alabama, we have trained them on chemical hazards, plus they have the personal protective equipment. Even though it's not much, they do have some equipment in their facilities, and this is just in case somebody shows up at their site, either a one-patient type accident where there's been some contamination or a large event. So we'll talk about what we've done to prepare them for that. Number 7 is surge capacity and resource management. We think all healthcare facilities are subject to surge problems and resource problems, and we'll touch on that a little bit. We look at surge capacity as an entire system event where hospitals and nursing homes and community health centers all have to contribute in some way, and community health centers have a unique function. So we'll touch on that. The hazard threat vulnerability assessment is something that some of our clinics understand well and some are still working on. But the hazard threat assessment really defines what your risks are, and we'll talk about how we do that. Then we'll close off the session showing you what's available at the university here and perhaps what we can make available to any of you. Let's go ahead and start with what I think is the driving force behind this. The NIMS system, the National Incident Management System, has been in existence. My memory is now 2004, I believe, so we're almost 10 years out. And NIMS was the document created by the federal government that says we want all response agencies to have a standardized all-hazard response system in place. We noticed over the years people doing lots of different things, all accomplishing the same goal, but the response wasn't standardized. So NIMS created this document that applies to all response agencies, including police and fire and governments, county, state governments. But for healthcare facilities, it's a unique fit in that we generally are not heavily command-oriented agencies, but we do manage patients, manage care, and we have to fit into the NIMS system. It's the standardized approach that says if we have to come to each other's aid, at least we kind of all look and act and feel the same. We have common systems in place, and it makes the response a little more uniform. So that's really where we build off of, is the requirements that NIMS puts in place. There are 5 main components to NIMS, and when we do our organizational training, we will go in and look at their organizational structure, which is really their organizational chart, who's responsible for what, who's going to be the decision makers, who's going to be carrying out the activities. We really look at that organizational chart and make it fit what is required of NIMS, and we have to call that incident command. So really it's your organizational structure during a disaster that has to fit into your plans. We know everybody has a disaster plan, but what we've seen over the years is inconsistency in the planning. Some disaster plans will be 2 inches thick and some will be 10 pages long, and so there's a lot of inconsistency. We've put together a plan template that we'll show you in a little bit that creates some uniformity and at least then has a common document that all of our agencies can work off of. All of that's supported by the training and the exercises. There's a whole variety of training opportunities. We have now for 10 years been doing the bulk of the training in Alabama for healthcare facilities. So what we offer in-house and on-site, but also there's a requirement for FEMA courses that you can find online, and you have to have certain people trained in your facilities for the courses. You may have heard the numbers 100, 200, 700, and 800. But we'll go over that in a little bit. So the training has to be consistent, and the exercises, each agency needs to participate organizationally in an exercise, but also within the community, and integrate your clinic into all the other agencies within your region, your area, your county. So it's important to participate in the exercises. Item number 4 that's required of NIMS is resource management, and we believe that probably resources will be the most difficult thing for facilities to manage. When you run out of all of the proper supplies and all of the right stuff, it's going to be very difficult to manage patients and take care of your facility if you run out of the supplies that you need. So NIMS requires that you look at how much of the right stuff you have, when it goes away, where you get more supplies, more drugs. Resources is a big, big piece of NIMS. And then the 4th is the communications and the technology. Everybody is required to have some sort of communication systems in place. And in Alabama, we have a system called the Alabama Incident Management System. It's an electronic reporting system, and every facility in our state is free to use that. And we'll talk about AIMS in a little bit. So the communications piece makes up the 5th component of NIMS. And when we go out and do our training and we verify NIMS compliance, we're looking at these 5 pieces that each agency needs to have in place. The NIMS implementation requirements were changed July 1st of last year. There are 11 elements that have to be in place. And what we have done is we've put together a NIMS compliance manual for community health centers. What we've done is we've taken each of the 11 elements and put them on a thumb drive. You can get a copy of this, print it off, and basically take a 3-ring binder and create 11 tabs. And each tab will explain what the element is, what you're required to accomplish, and then we will give you examples of those things that you need to do. We'll kind of walk you through it step by step. And if you can follow this document that we'll send you, it'll help you comply with the NIMS requirements. This is a copy of the NIMS compliance plan template, and this is what we can send to you. Everyone now has to be, when I say everyone, healthcare facilities have to be in compliance with NIMS. The July 1st, 2012 update from Department of Health and Human Services changed the requirements, and it says now all healthcare agencies must be in compliance with NIMS, and the carrot on the stick is funding. So you must be compliant with NIMS to maintain your eligibility for disaster funds. Now, in Alabama, because the Alabama Department of Public Health manages this program, virtually just for the fact that you're a healthcare facility in Alabama, you are eligible for that funding. Very few, if any, folks in Alabama actually get funding directly to them, any cash in hand. It's all secondary through training, exercises, supplies, materials. So our goal is to make sure that community health centers are compliant so that they stay eligible for all of that that's available in Alabama. And so far, that's worked out very well. So that's how we manage NIMS compliance in Alabama. It's something foreign to some folks. Others have heard of it, but we help the agencies come into compliance. And one way we do it is send them the notebook, and they can do it themselves, or they can invite us up to one of their sites, and we'll sit down with them and go through the book. So that's sort of the one-on-one way we can help become compliant. So that's the driving force. NIMS is the federal program that says you have to do this. We all need to look and act and feel the same, and it's all about organization and structure. The incident command is a subset of NIMS, and that's that piece when we talked about one of the 5 elements of NIMS, the organizational structure. Incident command is that piece. This is a very military, police, fire-like system. It wasn't originated in the healthcare system, but because we're part of NIMS, healthcare agencies have to kind of fit into this overall incident command system. The model looks like the typical organizational chart, and it is the basis of who's going to do what, who's going to be assigned what responsibilities. And what we want is healthcare facilities to look and act like other response agencies up to a point. The command-driven structure is not necessarily how we function in healthcare facilities. We are more management-driven, and so my preference is if within a healthcare facility you would call this incident management rather than incident command. I think that fits better the way we think about taking care of patients. However, NIMS requires we have this model in place. So if you look at the typical ICS chart, you'll have the top section that is the command, unique function of public information safety liaison. And if you notice there's a blank space in that top command staff, a lot of times we recommend you put legal counsel in that box. These are people who have to make decisions sometimes at the spur of the moment. A safety officer or legal is going to have to make a decision that a facility may or may not want to take some path. The commander has to be in charge making those organizational decisions, and your incident commander will be someone like your administrator or CEO. So that's the command staff up top. The colored boxes across the bottom designate unique functions within your agency. The logistics section, that's your stuff, materials, your buildings. That's usually what falls under the yellow box. Planning is administrative, information management, finance. Everybody can understand green and the finance piece of money in and money out. And then the operations section, the red box, that is typically where your mission lies. It's your activity. In healthcare, I like to call the operations section the healthcare section because that is our mission. That's what we do. And if you look at a typical organizational chart in a healthcare facility, particularly a clinic or a hospital, the vast majority of people are operational. They're clinical staff. And so you'll see the red box really dominate organizational charts because that's what we do. We are an operations section, which is the mission piece. So that's the ICS model we go out and train community health centers to fit into. And a couple years ago, we put together an incident command chart specifically for community health centers. And you notice it's very similar to the other chart. I think it has the colors reversed on the bottom. But what we did was we took positions and plugged them in so that it would give you an idea of who in your organization might take on those roles. So, for example, incident commander, like I had said, it could be your administrator or your CEO. Liaison officer, as the representative of your agency, sometimes that would be nursing director or another administrator. You can mix and match these positions. One of the problems is if you have a small agency, there will be more than one position per person sometimes. We like to have one job, one person, but that doesn't necessarily work out. And then we've broken out the operations, planning, logistics, and finance sections a little more specifically as to some of their functions. Now, what we have found is that we like to take the agency's day-to-day organizational chart and rather than convert it totally into an incident command chart, we take the previous chart that had all the colors that were the basic design, and we try to shift those over onto your day-to-day organizational chart so you see that it's a transition from normal day to emergency, right back to normal day. And we have had a lot of success doing that, and you'll see in a little bit when we talk about the training. We will actually go on site, get the organizational chart of a community health center in advance, work through it, do a presentation, and actually convert one chart to the other so that you have a kind of a seamless transition from day to day to emergency. And that goes over very well, and people really then begin to see, oh, the incident command is not much different than what we do every day. We just help make sure you get you fit into that compliance piece. So these are suggestions that are available to you, and you're welcome to use this and make it fit your system. One of the other things that we've done, several years ago we were asked to put together a community health center emergency management plan. And what we did was we took a lot of the best practices of plans that we were able to find across the country and some of our experiences, and we put together an emergency plan manual. That's what this is. And we purposely changed the name from disaster plan to emergency management program manual. And really one reason is Joint Commission began calling this emergency management program in their documents. They call it the EMP. So for those places who are Joint Commission accredited, you'll understand the EMP program, that terminology. For those that are not Joint Commission accredited, that's okay, because the same document applies. It doesn't matter whether you're Joint Commission accredited or not. So we put this together a few years ago, and it's a very basic kind of fill-in-the-blank plan. I would say 80% of the document is written, and then you can go through it and plug the name of your facility in. It'll walk you through how you create unique call lists and contact sheets for your area, for your community, for your region of the state, so that you can build specific documents that are valuable to you. And the table of contents, I know it's kind of small to read, but what we've done is we've broken this down into 10 fairly simple chapters. And the first is the general information about who you are, your policy, your objectives, your purposes, your scope, how you activate your plan. And it walks through those things that we think you should do, but it also will cover all of the NIMS requirements that are required to be incorporated into your plan. So we've written a lot of that for you. Again, you get a copy of this. You can kind of walk through it page by page. And it almost, not exactly, but it really does kind of write itself. If you spend a little time and fill in the blanks, you'll get 95% of it done probably at the first try. One of the things we've done is, if you notice up at the top, there is a header for each page. It allows you to track things like when this document was written, when it was revised, what revision you're on, 1, 2, 3, 4, who did it. And that's a real simple tracking tool so that you know when and how your plan was updated, and that's one of the 11 NIMS requirements, is you have to do this once a year. Also, if you look under each chapter, for example, Chapter 1, General Information, there's 1.1, 1.2, 1.3. We did this on purpose so that if you need to revise Chapter 1, Section 1.1, it might be 2 pages long. You pull that section out, you make the changes, you plug it back in. It doesn't change the entire format. You don't have to print off the entire document every time you make changes. We've done it piece by piece, and the electronic version of this actually breaks out each one of those sections as a separate file so that you don't have to edit 60 pages. You can only pull out 2 or 3 and make the changes that you need. So we've gone through, and the table of contents will cover general information, notifications, that's internal, external, who you call, the phone lists, continuity of operations, how do you keep your facility open, generators, those sorts of things, staffing issues, incident command. You can read all of those. And then over in Section 10 are the annexes, and what we suggest is that once you identify all the hazards within your area, there is a separate annex for each one of those hazards. There's an evacuation. There's evacuation for floods. There's surge, there's snow ice, internal disaster, fire, weapons of mass destruction. Those are examples that we put in there for you. But that's how we've broken down the plan. It seems to work well. It's probably no more than a ½ inch thick. We like to keep the plans short and simple. So again, that template's available for you if you would like to look at that. One of the things we've done in Alabama is we've included the community health centers probably going back now 6, 7 years. And they first started coming to our in-house class, the 2-day course that we do on campus here. And one of the things that we've always done is a chemical radiological exposure event where you have contaminated patients. Last year we added in a blast explosive piece to that. And it obviously, you know, a community health center is not going to be, it's not going to be an emergency room type facility. It's not going to be somebody receiving dozens and dozens of patients unless the event just happens to be right next door, across the street, down the block. We had some tornadoes come through Alabama a little over 2 years ago, and even though the community health centers weren't too involved those days, they could have been. And so over the years, we've included them in the what if somebody does show up, and we walk you through chemical exposures, what the agents are, what type of personal protective equipment you need to wear. And in Alabama, ADPH has put some chemical exposure equipment in the clinics, and I'll show you what some of that looks like. The way we approach this is, even though the funding originally was over terrorism prevention, the most likely event for chemicals, radiation, or blast is going to be some accidental event, industry, transportation. It's not out of the possibility it could be an intentional man-made event. But we go through and address each of these things, ask people what's in their community, do they know where their risks are, have they identified them through the local emergency management. And so we help them when they write their plans to make sure that these types of events are included in their annexes, so that they have a chemical plan, they have a decon plan, a PPE plan. So that's how we use this information to help them get their plans in place. The course that we do on chemical decontamination and protective equipment is probably a 2 to 3 hour block in our course. And we treat healthcare employees as first receivers. They're not the first responders like fire and police and EMS. Those people actually go out to a scene and recover and deliver patients to hospitals. But because people could wander in, and most of the healthcare facilities are going to have a secondary exposure from the patients who show up, OSHA has said we don't have to consider you a first responder, you're a first receiver. So that makes a huge difference in the decon and PPE procedures. So we make sure that that's understood, and we teach up to that level that's required. And this is just a summary of that section that we do, that you're obligated to at least receive these patients and do the minimal. We want to make sure that the employees are protected, your facility is protected, other people there, you know how to isolate them, you know how to set up a decontamination center, how to process the patients. And the level of PPE, the personal protective equipment, what we train healthcare first receivers to use is level C. There's A, B, C, and D. D is the universal precautions PPE that we're used to every day: gloves, masks, face shields, gowns, those sorts of things. Levels A and B are those first responders fire, hazmat, industrial rescue. Those people are going in completely encapsulated suits that we'll never see and we'll never wear. But for you to protect yourself, and the CHCs in Alabama have a minimal amount of this stuff, the equipment looks a little bit like this. The picture on the left is a chemical suit, and that person has on a full-face respirator. It's called an air purifying respirator. It's got the big filter that's hanging down from the front of the mask, and that's a mechanical device, meaning that the person wearing that filter actually has to breathe in hard enough to get air through that filter. It purifies the air, and so they're getting a clean breath. Whereas the picture on the right is really what we prefer, and that is what's called a PAPR. It's a powered air purifying respirator. Those guys have batteries and belt on their belt, and there's an air pack and a pump in the back. It has 3 large filters. It mechanically pulls the air through the filters, pumps it into the hood, and they're completely encapsulated in chemical-resistant suits, gloves. They don't have boots on the outside, but they could. And that level C picture on the right is what we've equipped people with in Alabama. So all the hospitals and the community health centers have a minimal amount of gear in case patients do show up. So we make sure that you know how to put the gear on, how to set up the decon equipment, and get training, we hope, at least once a year so somebody knows how to protect themselves and the facility and clean off patients. So that's our PPE decon course. Everybody that we train in Alabama gets surge capacity and resource management training. And we think this particular topic, it goes on probably for about 2 hours of the 2-day course. It spells out all of the things that cause surge issues and resource management issues. And if you think back to the NIMS requirements, these are included in those 5 components that we have to address. The way we define surge in Alabama is the ability of the system to rapidly expand. And I can give you a couple examples of what we've experienced. These expansions are going to be sudden or sustained, and the sudden was the tornado event that came through Alabama 2.5 years ago. And granted, the community health center is not an emergency room, but to give you an example of sudden surge, one of our hospitals that was virtually at ground zero of one of the storms normally saw about 200 patients in their ER in a 24-hour period. They saw somewhere between 800 and 1,000 in 6 hours. So they saw 4 times the number of patients in 1/4 the time. And that's because they just happened to be less than a mile, probably a half a mile from where a huge number of patients came from. So that's typical of a sudden surge. And in this case, the community health centers just happened to be on the other side of town and weren't close by this huge influx of patients. If they had been, there's no telling how many people may have just walked up to that community health center looking for care. So you can't rule out being involved in that. Where I think community health centers will get involved is in that second statement, sustained increase. If you think about a community health center, and I call them outpatient machines because community health centers are really geared for patient flow and getting in and being seen and sent back home. And if we had had a pandemic outbreak where we were seeing 25, 30, 40% of the population sick with the flu, that's a perfect place for all the community health center clients and patients to come back. The increased demand, the emergency room's full, the hospital's full, somebody needing care, that's very typical of an outpatient support. So I could see community health centers really being hit hard with surges in a long, drawn-out infectious disease event. So we make sure when we train community health centers about surge, we point out those things that they're likely to see, those things they're not likely to see, and help them gear their plans to respond to the things that they're most likely to have to deal with. To complement this, we train our healthcare facilities on hazard threat vulnerability assessments. This is something that you may have heard called an HTVA. And the reason we like to do the hazard threat assessments is that, first off, it's the right thing to do. When you do an assessment of your hazards, you've then identified all the things that are the greatest threat to you. The other is, if you're a Joint Commission accredited facility, they require that you do a hazard threat assessment once a year. So locally, your community, your emergency management agency does a hazard assessment for your entire county or community, and then you need to do one specific to your healthcare facility, internal hazards, external hazards. If you remember back to the disaster plan template, Annex Chapter 10 were all of the annexes. We like to have folks identify all of their hazards using their hazard threat assessment, list them all, and then make sure in your annexes you have a short plan that says how do we respond to an infectious disease outbreak, how do we respond to fire, how do we evacuate, how do we respond to a mass casualty, and your hazard threat assessment will define those sections of Chapter 10, and then you can write a 2 or 3 or 4 page operating procedure on how you respond to each of these hazards you've identified. So I think it's a good tool. This is a sample of one of the pages, and the hazard threat assessment, this one comes from the Kaiser facilities in California. You can see it's a dated form. It's about 11, 12 years old, but it's a good example of how you have all of the events listed down the score sheet on the left side, and then all of the impacts across the top, the probability, the human impact, property impact. You have to score all of these things. And in the end, after you've done your assessment, it will basically list those greatest risks, those things that are the most likely hazards that you're least prepared for, and then you can take that information and build your disaster response plan from that list of hazards. The nice thing is these things are online. You can go online and find them, and you don't have to do them by paper anymore. You can if you'd like. So we could direct you to some sites where you can just search online and find these hazard threat assessment tools. I mentioned this earlier, but once you complete your hazard assessment, this really then helps you define your plans and procedures and who's responsible for what during certain types of events, alternate facilities. All of these things really follow along. Once you've identified what your problems are, then it kind of helps you fill in the blanks and write the plans. Of course, then at the end you test and you train on those hazards you've identified. Let me just talk a little bit about who we are. And you'll notice here it's called the Advanced Regional Response Training Center. That was the name of our program going back 8 or 9 years. And we have not changed the name of our program because everybody in Alabama recognizes it. Just recently in the last year, we were able to call ourselves the National Center for Disaster Medical Response. We do have a reach outside of Alabama, but for me, because everything in Alabama is so close to home, I still like to call ourselves the Advanced Regional Response Training Center. In fact, you can go to ARRTC.com and you can find all the information about our programs. So even though we're a national center, I still like to call ourselves what everybody knows us by. Now we are on campus at the University of South Alabama in Mobile, and we offer a whole variety of programs, and I'll touch on those in just a second. We do a basic course on campus, and it's a 2-day course. And we also do a roadshow course that's done on site and it's a one-day program. The courses come from this menu. We have a set agenda for the basic courses. We'll do 15 of those a year. And the nice thing about our training is that ADPH allows us to do this for the students at no cost. We will pay their mileage to drive to Mobile. We'll put them in a hotel for 2 nights. We'll provide the training and the continuing education at no cost. Now, that's within the state of Alabama. If someone from outside of Alabama would like to come, the course is free. The continuing education, of course, is free. But because you're not an Alabama resident and this is an Alabama grant, you just have to pay your way as far as your travel. And we can help arrange that for you, but that's the only thing that we can't pay for non-Alabama residents. If you have a program in your state, most of the state health departments are the agencies that receive the federal funding for healthcare preparedness. You might want to ask them if they would be interested in working with us to either set up something like this for your state or make this available, and we'd be more than happy to talk to your state health department if this is something that you think somebody might be interested in. We do have a 10-year history. We've gone over 10,000 students, and we seem to get really good results, and everybody enjoys coming, and I think we've hit on all the right topics. If you look at the things on the menu here, you'll see a lot of these things we just talked about: surge, hazard threat. We do the introduction to ICS and NIMS. We also do a biological awareness piece, the biohazards, both intentional releases and natural outbreaks. We cover all of that. The patient decontamination and personal protective equipment, I showed you those slides. We will actually put all of the students in the chem suits, teach them how to put it on, take it off, and everybody seems to really enjoy that. So you can see all the topics that we provide. Most of them we can take on the road. We'll pick from the same list. We'll find a facility would like to host a one-day session. Again, there's no cost to the agency for us to come, and we'll pick from this list, and we'll do a one-day course and bring in, of course, bring this continuing education certificates along with us. That's very popular. The road shows that we do, we may be able to go into a hospital or a community health center and get 40 or 50 or 60 people. We have one set up for tomorrow. We have 78 people signed up. That's a big bang for the buck. If people come to our own campus course, usually 1, 2, or 3 people from a facility will show up, so we don't have quite the reach that the roadshow does. So that's why we started doing that, and that's been really, really successful. So again, at the end of this presentation, you'll see how to get in touch with us, and we're more than happy to talk about how we could help set something up where you are. Just a little plug of what we look like. We have a classroom that will hold up to about 100. 75 is comfortable, and up in the right corner you'll see that website I mentioned, rtc.com. It has information on the courses, the schedules, how you register, how to contact us. So feel free to go to that website and see a little bit more about us. Another course that we've added is what we call our simulation course. It's human simulation. We have access, and through some grants we purchased some of the human simulators. They're the computerized mannequins that you'll see in a lot of healthcare facilities for training purposes, on campus for academic purposes. And so we will use those simulators to replicate emergency response events. And this was really driven by comments we heard after the tornadoes. Healthcare professionals who said that it had been a long time since they had done triage. They couldn't remember the last time they worked in an emergency room, the trauma they saw, how to manage that. So the request was, we'd like a hands-on course. So we do a one-day simulation course. We'll create 4 scenarios, and you'll see the list of them. We'll do a mass casualty triage where we'll put all the mannequins out, and you have to go through and sort them and tag them and put them in priority, and then we'll change their status on you as soon as you turn your back, and then you have to go back and re-triage. And so that's a very popular scenario that everybody wants. We'll do impaled objects, crush injuries, amputations. We have couple of pediatric simulators. We'll do pediatric trauma. We'll do a drowning. We have a chemical exposure and decon where we'll put the students in the suits. They have to decontaminate and treat the patients, treat the mannequins in the gear. And that is difficult because you can't hear and you can't see well, and you got those thick suits on and the gloves. But everybody seems to enjoy that scenario the most because it's a challenge to learn how to do it. And then the last thing there, you'll see we have a customized scenarios where if a team wants to come in and they want unique training, just give us the scenarios you'd like. And we work with the College of Nursing here, and they will develop the scenarios for you. We'll do 4 scenarios in a day, 2 in the morning, 2 in the afternoon. And again, this is paid for folks in Alabama, and the continuing education comes along with that. There's some pictures of one of our classes, and you notice down in the lower left corner the people in the chem gear having to go through the decontamination and treating process. So that's our simulation lab. One last thing is we've always felt like every healthcare facility does well with their disaster planning if they have an individual who's dedicated to that. So we're in the process right now of developing a healthcare emergency planner professional course. This is not just a 2-day come in and get the basics, but this is a prolonged over weeks or months course, very similar to like an advanced degree program that you do online. We'll do some of it on campus, and some of it we'll do through distance learning. And in the end, we're going to offer a certificate, which would be a Healthcare Emergency Planner Professional Certificate. Our goal is to host the first class this spring. We probably will limit the class size to 15 or 20. And our goal is to do this a couple of times and then figure out how to convert this to a degree program so that in the end, there is a person who finishes our certificate course or degree course, hopefully in the future, and then they can go back to their facility and be the certified emergency planner for that site. And we think that would be a huge help in creating consistency and uniformity if we could get this to happen, especially in Alabama. That's our goal. So we're adding that course in, and there'll be more about that as the year evolves. This is the last slide, so I just wanted to remind you again who we are. We're the National Center for Disaster Medical Response. Also in Alabama, they'll know us as ARRTC. We're on campus at the University of South Alabama. If you know anything about Mobile, we're sort of on the west side of town. Nice location. We've got great facilities. So anyone who would like to come, please get in touch with us. You can find me or the Associate Director, Carolyn Ross, at those email addresses, and you can find us at that phone number. So that's a very quick hour of who we are, what we provide, where we are. And again, we are more than happy to get into discussions with you about how we could make this available to you, and if not us doing the training, at least sort of give you the template of how to set one of these programs up, and we'd be happy to help you with that. So any questions? I'll turn it back over to Johnette and see if there are any questions.
Great. Thank you, Mr. Wallace, for providing such an outstanding presentation to the Health Center staff and our other attendees. Just to remind everyone who's attending the webinar, if you would like to ask the presenter a question, please submit it through the question box on your control panel. If you are dialed in through your telephone and would like to verbally ask the presenter a question, use the raise hand icon on your control panel and your line will be unmuted. So Mr. Wallace, I have had one question come in, and someone would like to know how they can get the manual for compliance.
Well, if is the last slide still up on the screen?
With your contact information?
Yes, with my contact information.
Oh, yeah. Well, we will email copies of these slides out to everyone, so they will have your contact information.
That is the easiest way to get in touch with us. Either call that number or email either of us. And everyone here, we're a small office, so everyone here knows what the manual is and can get that to anybody that would like it.
Okay, great. Thank you. The next question is there a guide in the NIMS manual to organize partnerships with other community members?
Well, there is, and it is sort of a spin-off of the NIMS program that went into effect July last year, and it's called Healthcare Coalitions. And the federal guidance now is directing the state health departments to create these coalitions that are generally in they're an area or a region. It's a collection of maybe counties, and there's guidance in there about how you develop community collaborations, how you get with those people, create the contact list, learn from each other who does what, who has what resources. So your best access there would be either through emergency management or your local public health, because they will know about that new requirement, and it's called Emergency Healthcare Coalitions. That's been mandated now about a year.
Great, thank you. This next question, I think, is actually sent to both of us. Someone would like to know, will the copy of the presentation also include the Emergency Management Program Manual?
We can make that available. It's not part of the slides, but again, if they would like that, we'll be happy to send it to them. All they need to do is get in touch with us, and we'll either email it to them or mail them a thumb drive with it on it, just however they would like it.
Great, thank you. The next question is, have you helped other states set up similar programs?
No. We have tried over the years, and to be honest, I think the way this healthcare preparedness program was set up initially was very state-centric. Each state received funding to do things, very specifically required Alabama to do things, Mississippi, Georgia, same guidance, but we've made this available. Honestly, I think most states develop things on their own. But we have found over the years that as people change and programs change, we've become a little more known. So we are more than happy to talk to somebody and see if we could help set something up like this in other states. We have about a 10 or 11-year track record, and we can tell you what works and what doesn't work. And so be happy to help somebody do that.
Okay, thank you. This next question is kind of similar to that one. When natural disasters strike, is there a process to begin taking/seeing patients if you cannot get in contact with your state or local emergency medical response team?
Well, there's kind of a two-piece answer to that. The first is we jokingly refer to a facility's disaster plan as their yo-yo plan, meaning you're on your own. Most healthcare facilities need to have an emergency response plan that says if we can't get in touch with anybody, if the situation's bad enough that we're on our own, we need to have a plan in place that addresses how we manage patients until help arrives. And then the second layer of that is once you get through that initial response piece, then all of your community and regional planning, all of those things start to come into play. You'll see EMA and public health and other healthcare agencies kind of popping up out of the initial response, and those collaborations that are in place, the meetings that happen, the exchanging of names and phone numbers, all of this is, I think, once you get past the initial response that you have to take care of, 80 to 90% of disaster response is knowing the right people to call when you need help. And that's where we really focus in on our training, how to build these community collaborations, how you do it, how it supplements your individual disaster plan. And that, I think, is the most important piece that we do. We really spend a lot of time helping build those two layers, because at some point it's going to exceed your capabilities and it's going to blow right past your own disaster plan. That next layer needs to be in place, and we can kind of help you with that.
Great. So, Dr. Wallace, kind of along those lines, should health centers plan on having a trial run of a natural disaster or emergency response?
I think you broke up a little bit, but you're talking about a trial run or like an exercise?
Yes.
Yes. One thing that we've done at a couple of sites, one in particular, there's a community health center sort of in the south central part of the state, and we went down and did a hurricane exercise, and basically we tried to replicate surges of people evacuating the coast and stopping 100, 200 miles inland and not having anywhere to go and can't get back home. And so we did that exercise to kind of test their surge. So yes, we encourage the training, and we also encourage exercises to test your plan, see if it's correct. The best time to fail is during an exercise, so that you find the problems beforehand. So yeah, we encourage that, and we help folks set up exercises and help the training and exercise piece all the time.
Great, thank you. And the last question, since we know that natural disasters can be pretty expensive for communities, are you aware of anywhere that health centers can acquire additional emergency funds?
Well, I think the first place is to reach out to the state health departments. And the way the federal funding is designed is that it goes, in most cases, it will go to that state health department under something called the Hospital Preparedness Program, HPP. So the first place I would reach out to is state public health. The second is either your community or your state emergency management agency. They have access at times to Homeland Security funds. That's another a good place to go. And then third is I like to encourage community health centers to set up a collaboration with a large hospital nearby, because sometimes hospitals are able to access disaster funds that maybe community health centers can't. If you have a good collaboration with a hospital, you can kind of be included in that. So I think those are three good places that somebody could look for funding.
Okay, great. Since it's almost 2 o'clock, I did want to go ahead and wrap up this webinar presentation. Thank you again, Dr. Wallace, for such a very informative webinar. I'd also like to thank everyone for taking the time out of their day to attend this webinar. In conclusion, I just wanted everyone to know that the copy of the PowerPoint slides will also include resources for creating emergency preparedness information. This is our contact information, so if you have any additional questions, feel free to reach out to any one of our staff members, and we will be more than happy to assist you. One reminder is we just want to let everyone know that we will be sending out save the date information very shortly on our upcoming National Symposium, which will be held in the spring of 2014. And thank you once again for joining us today. At the conclusion of today's webinar, we will email all attendees a copy of today's presentation and a recording of the webinar. Enjoy the rest of your day.
Thank you.